Hi, everyone. I'm John Miller. I am Executive Director of the Mid-Atlantic Business Group on Health, and it's my honor to welcome everyone to our Collaborative Care Forum today. The Mid-Atlantic Business Group is a co-sponsor of the Mid-Atlantic Forum, the Mid-Atlantic Path Forward for Mental Health. We are poking our nose into this behavioral health issue because we want our employees and their dependents to be able to access the most effective and most cost-effective care available. And the collaborative care model provides that. In fact, yesterday, the Bowman Foundation released yet another report testifying to that fact. I believe we have Matt Bowman with us on the line, so thanks, Matt. And I've said my piece now, so welcome everyone to our forum, and let me turn it over to you, Linda, if I may.
Thank you, John, and a quick welcome everyone from me, Linda Rains. I am the CEO of the Mental Health Association of Maryland. We are a consumer advocacy organization and a co-partner with John's organization, working collaboratively with the business community to advance a goal that is near and dear to our hearts and something we've spent years now working on, and that is advancing better access to behavioral health services in primary care, because we know that is where most people come first when they're looking for help with a mental health or substance use problem. And so we're very appreciative of our speakers who have joined us today to share their tremendous work in this area, and also to all of you for making the time to join us on this webinar and, adding to the movement to get these best practices in care out there to the people that need them. So thank you. And without further ado, I will pass off to Michael Uhas, who has put this meeting together and is our moderator for the day.
Great, thank you, Linda, and welcome again to everyone. We keep our remarks short because we want to really spotlight the content of what we're going to hear from both speakers today. So Sam, do you have a slide for me, an intro slide? While you're, okay, if you've got it, I'll take it. There we go. So just kind of a quick recap for those of you who've been on prior webinars. We started these last summer. We held 3 of them, and we weren't really quite sure, depending on the reaction, the response, how we've continued, but we are continuing them. So we're excited about today's session in particular. But a reminder, these are all on Fridays from 12 to 1, and that's deliberately to help allow the greatest number of attendees from the provider side, particularly. Everybody on this call has busy schedules, and we figured a lunchtime on Friday would do as well as anything. They are also recorded. So after the event, you can go to the Mid-Atlantic Path Forward website, which was contained, there's a link to it in the invitation you received. If you need one, let us know and we'll give you one. But you can see all of the presentations online as well. Each session has 2 presentations. They're 15 to 20 minutes long, followed by maybe a 5-minute Q&A. We also have a chat box that we may or may not be able to answer all questions live if they come up, but we'll certainly try. And we did get a few in advance. The major focus in all our presentations is really on putting together a collaborative care program with Fidelity. Even if it has variations in it, it should meet the model that I'll show you in a second, and you'll recognize instantly. We look for how these came up and got put in a position to become sustainable models. And most importantly, perhaps, is understanding the barriers that people encountered in putting together the programs. And the lessons that came out of it. And finally, on this slide, we've already mentioned briefly, John did the Bowman Family Foundation, as well as the Sylvan C. Herman Foundation. Both of these organizations, philanthropic organizations, allow us to do what we're doing today. And we give just a huge thanks to both organizations for letting us do this and having the confidence in us. Next slide. Okay, so just a word on the big path forward. So we're talking about the Mid-Atlantic Path Forward putting this event in. It is an affiliate of the Path Forward Coalition, the national coalition, the Path Forward for Mental Health and Substance Use. It is it's a coalition designed to focus on a few things that are doable in the relatively short term that can impact access to mental health and substance use disorder care. Along the bottom of this slide, you'll see the 7 key partners that support the Path Forward Coalition. And you'll see the Bowman Family Foundation again. You'll also see Meadows Mental Health Policy Institute toward the right. And Dr. Hani Talebi is one of our presenters today. So next slide, please. The Path Forward has probably, I don't know the number, John, and Matt may know more than I do, but there are dozens and dozens of employer coalitions that participate in one way or another with the Path Forward, and the large purchaser coalitions that are partnered with the Path Forward. The eight that you see listed on this map, including the Mid-Atlantic on the far right, these are more or less the operating partner regions where a number of the initiatives that are put forth by the Path Forward get implemented, they get put into action. So they're, coast to coast. Next slide, please. Okay, just a note on when we're talking about collaborative care, we recognize and respect the fact that there's more than one way to integrate behavioral health into into primary care, and more into specialties such as pediatrics and others. But the model we're talking about in these sessions is the model that we all have seen come out of the AIMS Center. We've seen other depictions of it, but it's where the patient is at the center of everything. The primary care or pediatrician or specialist, as these are specialties growing in collaborative care, retains responsibility for all patient care, prescriptions, etc., but with the support of behavioral care managers and a psychiatric consultant, one or more of each. And there are specific requirements. There are codes for billing and collaborative care, as most, if not all of you know that. And there are requirements, which include the registry, includes measurement-based care, and so forth. This is the model we're talking about when we say collaborative care. Again, we'll see some variations on these, but this is the fundamental one. Okay, Sam, next slide, please. And today we have 2 speakers that are going to spend a little bit of time with us. And again, the bio sketches that you're looking at right now will be posted on the website. So you'll have an opportunity to see these in more detail as well. But Patricia Dessau is going to be presenting from Kaiser. And for those of you who have already heard that the Bowman Family Foundation yesterday released a new issue brief on collaborative care and its impact on total care costs. Patricia, one of the studies we featured in that issue brief comes from Kaiser Permanente, and Patricia is going to be talking about that. So Patricia is the Director of National Mental Health Addiction Care Program at Kaiser. You can see on the screen kind of the areas of focus that she has. She has implementation oversight for spreading clinical care delivery programs in mental health and addictions. She has worked with the 8 different regions within Kaiser, following the initial study that gave them the desire to grow a collaborative care model throughout all of their regions. So she worked with the AIMS Center and those 8 regional organizations to implement collaborative care nationwide or region-wide for their organization. I'm going to then, so the next slide, if you could just bring up Hani, I want to quickly let these folks talk and stop talking here. Sam, can you give me the next slide? There we go. So Dr. Hani Talebi is with the Meadows Mental Health Policy Institute, where he's Chief Clinical Officer, Senior VP for Health Systems Integration. Hani has spent his pretty much his whole career. He's dually licensed as a psychologist and a licensed specialist in school psychology. But he spent his career really advancing collaborative care, advancing the intersection of primary care and behavioral health care. He's an affiliate faculty member at the University of Texas Austin Dell Medical School, Department of Psychiatry and Behavioral Sciences. He has over 25 years experience in the industry, and in all of the roles that Hani has held, they've all kind of contributed to this intersection of behavioral health and behavioral health care and primary care. So this is somebody who spent his entire professional career doing the kinds of things we're just beginning to talk about. So with that, next slide, please. I think that actually may be it because the rest are kind of proposing. So if we can then, without further ado, I'd like to turn it over to Patricia and ask Patricia to spend the next 15 or 20 minutes telling us about the work that they've done at Kaiser and how they've managed to expand that now to all of 8 regions. So we can take Patricia's first slide now.
Great. Well, good morning and good afternoon, everyone. I am one, but I am representing many at Kaiser Permanente who have been instrumental in leading the way on our journey to advance collaborative care. Next slide, please. We have no conflicts of interest to disclose. Next slide. A few words about Kaiser Permanente. We are the largest managed care organization in the United States, an integrated system of care and coverage together. We operate in 8 regions, representing 9 states. We are 12.5 million members strong, with a workforce of over 300,000 physicians, nurses, and employees. Next slide, please. We have a national mental health, wellness, and addiction care program that has a bold vision that anyone at any time in any place can achieve mental well-being and recovery from addiction. This is our moonshot goal, our North Star, and we've built a strategy to help us get there. Our strategy includes 3 main buckets. First, make it really easy for people to get the help they need. Second, build out an ecosystem of care that shepherds members through their journey to wellness or recovery. And third, lead in our communities by partnering with them. Notice that collaborative care is prominently featured in our strategy. Next slide, please. Collaborative care, in fact, is a prominent part of our history. Can we go to the next slide? You could say that it's in our DNA since we have been involved since the conception of this model. 2 Kaiser Permanente sites in California actually participated in the seminal IMPACT trial at the turn of the century. In addition, Kaiser Permanente sites in California, Colorado, and Washington also participated in the COMPASS and Team Care studies, showing the benefit of collaborative care to patients with co-occurring depression and either diabetes or cardiovascular disease. Next slide, please. About a decade later, in 2011, one of our KP regions, Colorado, decided it was time to formally pilot a collaborative care program. The reasons were plentiful and included the need to address the high prevalence. They knew at the time that about half of high utilizing primary care patients exhibit significant psychological distress. Mental health concerns were prevalent and showing up in primary care. Another was the need to improve outcomes. Primary care physicians were struggling to help patients with chronic conditions, and collaborative care held promise to improve cardiovascular disease risk factors through reducing depression. Skipping down to the HEDIS antidepressant medication management metric, one of our quality goals, and this was a metric of special interest, and there was a lot of energy around improving performance. And collaborative care was just the right thing to do, and it was time. So that region put together a multidisciplinary team, including primary care, psychiatry, population health, quality, and more, and kicked off a pilot. So what was this pilot? It is important to note that at the time, KP Colorado had about 500,000 members. So starting small and growing from there was the name of the game. They decided to pilot a narrowly scoped program called Depression Care Management, or DCM. It would include a target population of adults 18 and over with a new diagnosis of depression and a new antidepressant medication start. Remember, starting small, and HEDIS was of special interest, so this was a medication-focused program. They employed care managers, behavioral health care managers who were registered nurses and had experience elsewhere in the system with other disease care management programs. Incidentally, they also used support staff to perform some of the administrative functions like scheduling appointments, sending out the PHQ-9. And with this shared care manager role, they were highly efficient and were able to handle very high volumes, caseloads, in some cases of up to 500 to 600 patients per year. The program was telephone-based and offered at no cost to members, and the interventions were primarily medication management, but also some brief interventions, including behavioral activation. The team structure was that classic collaborative care model that you see on the left, and the program consisted of at least 4 encounters with a care manager who would administer the PHQ-9, provide medication counseling, and titrate medication as needed in partnership with a prescribing physician. The total time that patients were spending in the program was about 3 to 6 months on average. This was their model, and they were off and running. What started off in one clinic eventually spread region-wide. So how did they do? They actually conducted an impact evaluation to study how they did in the time frame of 18 months in a period between 2012 and 2014. Sorry, can we go to the next slide, please? The study population was 908 patients who had completed at least 3 of the prescribed 4 encounters from the previous slide and had a baseline PHQ-9 within 30 days before or after the program start. And then also one of the subsequent PHQ-9s had to be at around 3 months later so they could do the pre-post analysis. The majority of the study population were commercial members, but it also included Medicare and Medicaid patients. The average baseline score of the study population was 14, which signaled moderate depression. And comparing the baseline and 3-month follow-up, a statistical analysis showed that for all members who had any severity of depression from mild and above, depression care management was effective. In fact, there was a statistically significant reduction in PHQ-9 scores for the categories with an asterisk. You can see here that these patients experienced response and/or remission of symptoms. Next slide, please. I'll travel back to Colorado in just a moment, but first, I did want to note that we have spent over the years a significant amount of time lifting up patient and clinician voices because their satisfaction and input is hugely important to us. These quotes, which we've received at various points in our collaborative care evolution, are peppered throughout my slides. I won't read them all, but I do want to give you just one sample here. On the right side, one of our behavioral health care managers recently told us, this program has proved really helpful to provide that support to patients and get them feeling better relatively quickly in a way that's pretty cost effective. Next slide, please. And speaking of cost, at the time in 2015, KP Colorado also did a cost analysis, which looked at total costs of care at initiation of treatment and 12 months after for both a DCM group and a comparison group. The DCM population here was 1,525 engaged patients, so completing at least 3 of those 4 encounters. And the comparison group was usual care. So they were started on an antidepressant medication in primary care, but without the care management piece. The big headline here is that the per member per month total cost of care was 13% less in the DCM group relative to the comparison group at 12 months. And the breakdown is as follows. I'm going to go from the bottom up here. They saw a reduction in avoidable utilization of hospital, ER, and urgent care visits. There was less need for specialty behavioral health and psychiatry because patients were being taken care of in primary care. There was some increase in non-behavioral health office visits and diagnostic services. This is to be expected because when depression is being managed, patients are more likely to tend to other areas of their health. They saw appropriate increases in pharmacy costs, presumably due to DCM being a medication-focused program, and there were decreases in all other services. Next slide, please. Soon after these analyses, a decision was made to spread DCM to other regions in KP. The reasons, which are on the right side, were plentiful. So at this point, we had seen in our own organization that it was both effective and cost effective. There were new HEDIS metrics coming onto the scene, and it was thought that collaborative care could really make an impact here. Collaborative care was also really nicely aligned with our Medicare and quality goals, including but not limited to performance on Medicare stars. And there was a need to continue improving access and providing a more accessible option outside of specialty behavioral health or psychiatry. And once again, just the right thing to do. So as we expanded to the other markets, the scope remained the same, but the focus was more on that moderate severity level. Think PHQ-9 around 10 to 19. The team members were the same, and most regions chose to do a primarily virtual program. Leadership support was key in getting this program spread across the enterprise, and you can see on the right bottom the different leadership and governing bodies that were accountable and offered their support and buy-in. Next slide, please. Over the next 5 to 6 years, we were able to spread DCM to most of our regions, and we pulled many levers in order to do that. I'll mention just 3 here. Number 1 on the screen, at the national level, we had dedicated implementation consultants, analysts, and physicians leading the charge. Number 5 on the screen, we created a national metrics dashboard where we tracked both process and outcomes. And number 6, we did a targeted performance improvement project with 2 of our regions using a patient-centered, equity-focused, human-centered design approach with the goal of improving engagement rates. Remember, at this time, we knew from Colorado that improving engagement usually meant more response and remission. We learned a lot when we were expanding depression care management across the enterprise. We learned that leadership support at the national and local levels was key in these leadership groups championing the program. Because we used a data-driven approach, we could see that outcomes were consistent with or better than the literature. In fact, at one time we saw that 1 or 2 of our markets were seeing response or remission rates at about 50 to 60% when patients completed the program. And we also learned that when primary care physicians endorsed the program at the time of referral to collaborative care, patients were far more likely to initiate and engage. Next slide, and then we can do one more. Keep going, please. With the success of KP Colorado's DCM model and building the foundation of DCM across the enterprise, we continued the journey and in 2021 decided to implement a fully scoped collaborative care program across the enterprise. We had the full support of several leadership entities, seeing at the right bottom. And the why we did this is very significant on the right side. So we were in 2021, peri-pandemic. There was increased demand for mental health services due to skyrocketing rates of mental health issues. We had at this time also seen even more evidence of effectiveness. The evidence was showing that collaborative care was twice as effective as usual care, reduced the total cost of care, had a 6-to-1 return on investment, and alleviated outcomes disparities, which was aligned with our evolving diversity, equity, and inclusion strategy. We made some significant additions to our model to expand it. So now, in addition to new diagnoses, we were including existing diagnoses, still for patients 18 and above. In addition to depression, we were including anxiety, the 2 most common mental health conditions showing up in primary care. We kept the severity the same, and the interventions were to be not just medication treatment, but also counseling, including problem-solving treatment. And we expanded the suggested licensures for care managers. This was the model that we were pushing out to all of our markets. By the way, you might notice that the graphic in the middle of the screen got an upgrade. It got more diverse, more colorful. This was more than just incidental. This was a representation that representation matters, and an assertion of our strong commitment to equity, including but not limited to parity in outcomes, culturally responsive care, and designing at the margins. No one was going to be left behind as we moved forward. Next slide, please. In this current iteration of collaborative care that we have now, we have a strong emphasis on high fidelity to the evidence-based model, ensuring the 5 essential components on the left here are in place. That said, our regions can and have augmented their local programs with some enhancements. A few examples are, one of our regions has gone ahead and included adolescents. Another region has added other members to the care team, including a clinical pharmacist and a virtual care clinician who assesses and refers patients coming in through electronic visits. We have one region doing social health screening, and others are doing a weighted priority system as a means to increase equity. So what this means is as these programs are building up, those patients who are in one or more underrepresented populations, for example, high social health needs, non-white, below 18 or over 65, are given priority to the program. Next slide, please. And one more. How it's going. We have currently launched and expanded in 7 of 8 of our regions, with the 8th region pending. We are not piloting, we are not in beta phase. We are doing this, we are launching and expanding. We have experienced many successes and challenges, a few of which I'll mention here. The first success I want to call out is our wonderful partnership with the University of Washington Ames Center. They have been instrumental in helping us design and author an implementation guide and toolkit that our regions have been using to stand up their programs, providing coaching and consultation support to our regions, and providing the care team training so that our clinicians can practice with fidelity to the model. We built a community of practice. We invite our implementation leads from all over our regions to come together and share best practices and resources. We created a number of tools and assets to support expansion. One, for example, is a financial cost model. And another is a video with member and clinician testimonials. We certainly have had our share of challenges, and a couple I'll mention here are the ability to acquire additional resources, specifically FTEs, is very challenging, especially when there are competing priorities, and building up caseloads. Standing up a program doesn't necessarily fill up care managers' caseloads right away, and it can be slow going. Some things that are on the horizon that we're very excited about is we are currently building the internal training capacity. So within our walls, building the capacity for our clinicians to train each other. And this is with the help of the University of Washington Ames Center is doing a train the trainer program with some of our clinicians. And we are creating a national measurement dashboard with disaggregation so we can continue to monitor our overall program process, outcomes, and equity, and make sure that we are accountable to the model. Next slide, please. As I wind down here, the slide before, please. As I wind down here, I do want to give one of our KP members the last word. This is one of my favorite quotes that we've gotten and really showcases how impactful and satisfying the program is. They said, I tell everybody about this awesome program that Kaiser has. Everything that this program has come to offer has been amazing. I think just having that support and knowing that somebody is there and understands what you're going through is a huge, huge thing for me. And last slide, please. As I get ready to take questions, I do want to say that you might have noticed a lot of foliage imagery throughout this talk. This is symbolic of our journey. We planted some seeds, we grew some sprouts, then saplings, then trees. The journey toward building a forest hasn't been perfect, and we've had our share of inclement weather that has impeded our growth at times. But we are eager to both share and learn as we continue to forge ahead, firm in our belief that collaborative care works and it's the right thing to do. And with that, I will pause for questions.
Well, first, let me say thank you, Patricia. That was great. That was a great presentation. Wonderful to hear. We did have one question come up in the chat box. Someone asked to hear more about the human-centered design project.
Yeah, so we have a method of performance improvement that follows the design methodology of a company called IDEO, which is based here in California. And it's a process that includes whoever the end users are. This could be for any industry, but in our organization, the end users are often the members, the patients, and the clinicians. So we bring them in for a design session, understand what some of their unique needs are, have them brainstorm and prototype solutions, and then we test them out on a small scale. And depending on how that works, then might scale the solutions up from there. So it's really about centering the members, the patients, and drawing on their intellectual capital about what some good solutions might be to the problem that we're trying to solve.
Other questions we have for Patricia? We have a few minutes. Let me start then while we're waiting. Patricia, you mentioned in one of the challenges the growing of the caseloads, the building of the caseloads, which we see all the time is an issue, and often it's a critical issue because of the need to get to a break-even point where you have enough patients impaneled in the program, so that the billing for collaborative care sustains the program going forward. Can you talk a little bit about how long it took you to hit that point where you felt like you'd hit the point of, break even relative to this is the minimum panel size that would really be needed to support a program like this? Can you say a little more about it?
Yeah, I don't know so much about the time frame. It is slow in the beginning, and I can say that it is highly dependent on the methodology by which patients are getting into the program, how effective that methodology is, and the primary care endorsement piece. So what we have observed in Kaiser Permanente is when there's a system of referral that includes the primary care selling the program to the patient, they are much more likely when the care manager outreaches to them, they're more likely to be familiar with what this program is and sign up for it. So right now, we have a few different ways that this is happening. There are patients who are being populated on a list through a registry automatically, depending on what criteria they meet, if they meet the inclusion criteria. And then the care managers use that list to outreach to the patients. But if there is no familiarity with what that program is, then it's kind of a cold call and the patients may not engage. However, if there's more of a direct referral from the primary care physician to the care manager, those caseloads are more likely to fill up. So
Okay.
can't speak too much to the timeline, but the process
Understood.
that's what we've observed. Yeah.
Thank you. We can, if you take one more question for Patricia, then we're going to move on to Dr. Talebi. One more question out there.
Something pop up in the chat.
Okay. Is 13 the youngest age enrolled in collaborative care? Is there anything done differently when focusing on youth? Can you respond? Is 13 the youngest age?
Yeah,
And
just in one of our regions, they've gone ahead and expanded their age of the target population to 13 and above adolescents. And that is just getting started. So we're still in a learning mode over there. And so I can say just generally what we know is the need to include families when we're dealing with younger kids and adolescents, but still a lot to see and observe and learn as we're just getting started.
thanks. And I suspect we'll hear a little bit more about this from Hani as well. But thank you so much, Patricia. Much appreciated. And now we'd like to turn to Dr. Hani Talebi, who will talk a bit about the kind of challenges and the successes they had in implementing a full fidelity collaborative care program at the University of Texas, an academic center, which has its own kind of environmental, I guess, needs or challenges. But Hani, if you would please, thank you so much.
Sure. Hi, everybody. Thank you so much, Michael Uhas and the team for inviting us today. I want to thank the Sylvan Herman Foundation and the Bowman Family Foundation. Obviously, their support is integral to keeping this going. I want to thank Patricia. That was an awesome presentation. I've always wanted to follow a UC Santa Cruz banana slug. Today is the day it happened. So thanks for that, Patricia. Kaiser Permanente and their presentation, a long-standing initiative, and they've had some years to kind of get those seeds planted and see those efforts grow, which is great to see. I'm going to speak a little bit about the other end of that spectrum today. We are roughly 8-ish months into a program at Texas A&M University, and we'll speak a little bit about the facilitators and barriers that we've experienced getting that going. The Meadows Institute really adheres to a lifelong trajectory for collaborative care and integrated behavioral health. To the question earlier about are things different for pediatric collaborative care? Absolutely. That context is very different. Patricia brought up a good point. Parents have to be involved. Schools have to be involved. Rating scales, consents can be different, all those types of things. So a lot to think about. We really are kind of hoping to get a system in place that supports all the way from perinatal care and moms and newborns through collaborative care to pediatrics. What I'll be talking about today is really the transitional age youth population, who's oftentimes forgotten. We really wanted to focus on the university setting, knowing that that catchment is so large for such a high volume of students as well, that a scalable program that is fiscally sustainable over time, like collaborative care, would be a natural match. And then having that shift into the adult and geriatric frame. So look forward to talking to everybody about that today. If you have questions, please feel free to drop them in the chat. One of my colleagues, Dr. Andrew Carlo, who's a lead on this project as well, is here, and he can also respond to things as we go through. Next slide, please. I have no conflicts of interest to disclose here. I actually wish someday that I would, to offset the massive amount of Amazon boxes that are on my front porch every afternoon. Next slide, please. A little bit about the Meadows Institute. You can do one more click and it'll bring up something else there, I think. There it is. Thank you. We are really originally focused on being a national leader starting in Texas for treating folks with mental health needs, where they need it, when they need it, getting evidence-based care kind of across the spectrum. But we are a policy institute, so bidirectionally, making sure that we have a touch point at the state policy level and local systems that will inform kind of national policy as well. Next slide, please. And then talking about a little bit of our unique value in that intersection, undergirded obviously by our values that are listed there. We take this circular approach that kind of is self-perpetuating over time, on the front lines, developing, implementing, and scaling financially sustainable evidence-based solutions in those different markets and systems, and then extracting those proof points from the projects that we have going, and then having that inform mental health policy both at the state and the national level, and then supporting the enactment of that policy, and then having those funds come back down and cascade to get more demonstration projects going and scaled projects so that we can really get things moving. Next slide, please. Next slide, please. So I'll talk a little bit about our project for today. The Texas A&M University is located in College Station, Texas. They have a university health services center that is essentially the equivalent of primary care. It's an on-campus healthcare provider for all students attending. And then all currently enrolled Texas A&M students are eligible to be seen after they pay a couple of different fees as enrolled students. These roughly are about $75 and $100. So hopefully nothing too torturous for folks to manage. Next slide, please. So for folks that don't know Texas, it is larger than any country in Europe, and we got all kinds of stuff happening in both urban and rural areas. You'll see a little red dot there next to Bryan. So oftentimes College Station Bryan is stated together, but in the College Station area, there's about 125,000 folks living there. In Brazos County, almost twice as much. The dearth of mental health providers, it kind of mirrors what's happening in the rest of the country, except it's a little bit worse in our rural areas that I would consider College Station to be, actually. So United States, if we're talking about 340 to 1, then Texas and Brazos County are worse than that. So what's close to it? Well, Houston's about an hour and a half away, and Austin is roughly 2 hours away. Those are the two biggest cities nearby for care. And so obviously secondary to the pandemic, telehealth has been huge for that student population, as well as kind of the folks living in that area. So it's still very, very difficult, though, when your index visit has to be with the provider, and making sure that you are able to lay eyes on someone ends up being quite a hardship for a lot of folks in this region. We like to think that Texas A&M is kind of one of the first universities nationally, based on our research, to implement COCM to fidelity through their student health clinic. And we feel very fortunate to have been a part of that process by providing technical assistance to get it done. Next slide, please. So a little bit about staffing and some of the other demographics of the site there at UHS. They have about 8 physicians, and then about 16 resident physicians that'll rotate through UHS. And then for APPs, about 17. They're not all full-time. There's a lot of rotating going on. But they do have one behavioral health care manager that we wanted to kind of scale this program without hiring too many folks at the kind of outset. And so that's an LCSW who's licensed, that ends up being a double benefit for folks who are familiar with collaborative care. Sometimes scaling a program, you want to make sure that you have someone who's able to drop billing for individual psychotherapy codes, as well as collaborative care codes, to really bulk up their capacity to increase those revenue streams. The good news is they are in the process of hiring their second BHCM. We've had some success early on. We'll speak to that in just a moment. Their treatment population age group, roughly 16 to 75 when we think about grad students and some of the other folks that can be enrolled in a campus. But the majority is roughly 18 to 24 years old. Huge student population there, 77,000, mostly undergrads, but a healthy amount of graduate students as well. What did the training look like when we got this going? This was a very unique setting for us. We're typically trying to piecemeal trainings together in a health system or an academic research site that is kind of has a clinic integrated into their institution. But this was really wonderful, and it stood out to us as an exemplar for something we'd like to replicate in the future, should it be available. But we had a summer in-person training, and this was really fantastic. Obviously, the clinic closes down in the summer because the campus is closed down in the summer. UHS closes down as well. They still have their skeleton crew there and managing things and preparing for the upcoming fall. But being able to get that entire crew of individuals from the frontline providers to the billing department to administrators, everybody in the same place at the same time, and then have breakout groups that were specific and tailored to kind of what they would be doing in that team-oriented approach to collaborative care. Was something we'd never had an opportunity to do. And we saw that in addition to kind of getting everybody on the same page with uniform language, standardized training, it was really about rapport building as well. A lot of those folks on the team at UHS didn't have an opportunity to kind of work with each other in the past. So getting everybody in the same place, and then rapport building for us, being able to provide technical assistance at different points in time as the program progressed, really allowed for us to have relationships with folks and feel that there was trust in getting those things going. By default, the American Psychiatric Association also has trainings online for BHCMs, psychiatric consultants, and PCPs. Historically, have all been free. Right now, the BHCM training is a paid training at around $350. So that ends up being an additional cost that folks need to know about if they're using those trainings as well. Michael was talking a little bit about caseloads. We were aiming for around 40 folks on the BHCM's caseload, averaging around a 12 to 16 week enrollment. Again, this is, looking at mild to moderate. We'll talk a little bit about around the service array for the campus at Texas A&M that plays a role here. But thinking about mild to moderate presentations, 12 to 16 weeks or so before they shift into a maintenance phase. Continuing prescriptions through UHS with one to two times a month, usually once a month check-ins for about 3 months afterward before they phase out of the program. This kind of target caseload ends up being, if you're rotating, 2 to 3 times a year, that's roughly 120 students or so, depending on kind of ebbs and flows of the calendar, especially at a student health center. We'll talk about that in a second. And then psychiatric consultancy, they had a psych NP from the University Counseling Center that ended up being a perfect fit for the psych consultancy role. This was actually really great when students were a bit higher acuity, because they could step up care right to her. They already knew her, or even better, the psychiatric consultant knew them well and their care and what they needed. So they could shift relatively seamlessly into that. An initial challenge, though, obviously ended up being coordination of care and tracking those students in COCM versus how best to oversee their care when they were stepping up or stepping back down. This is kind of a natural issue that folks run into, but something that can be worked through relatively easily with a workflow fine-tuning. Next slide, please. So what did startup look like and where did it come from? Texas A&M actually had attended, some of their executive administrators had attended a few different presentations that we had put on at the Meadows Institute, and they reached out to us directly to solicit our support in implementing the collaborative care program through UHS. I have to say they were exceptional. They were very eager to get programming like this up and running. This ends up being a huge barrier if you don't have executive leadership support. It's similar to not having physician support or kind of having those folks really feel as though they're involved in making a difference and this is the right program for them. They have a massive student population, and they knew that they had relative below standard outcomes over time clinically. They wanted to address that. Knowing that, again, thinking about the crisis array as well, deaths by suicide were at an all-time high, not just on their campus, but obviously across universities for this transitional age youth population. So they wanted to get folks universally screened, get measurement-based care in place, and try to get upstream to really support the student population early and often. So some of the facilitators that we saw and some of the really kind of positives that got this program up and running, we had not just the UHS, University Health Services Center, on board, but we were also working with campus police, the University Counseling Center, the registrar, the athletics department. Everybody was kind of on the same page about a very unique transformation that was happening on this campus relative to mental and behavioral health. And so having that buy-in and speaking the same language about what was happening was really huge and made a big difference on the front end. This was executive leadership driven without a primary focus on near-term reimbursement. Michael brought up this issue earlier, thinking about caseloads, thinking about where's our break-even point. Texas A&M was dedicated and committed to seeing this through, knowing that this was going to probably be, at the beginning, not something they were going to make money off of. They wanted to take care of these students. And we'll talk a little bit more about how they kind of offset some of that stuff. But they put this into their budget, knowing that they were probably going to be mildly in the red at the beginning, but they would be there would be significant cost savings later on when they're circumventing crisis care, when they're making sure kids are continuing to stay in classes, continuing to be enrolled, those types of things. I think for them, this was something that they were dedicated to, and it was really great. Physician champions on the front lines, again, much like executive leadership, they were hugely integral to ensuring that folks had buy-in, that they supported this new change on campus when it came to clinical workflows, billing workflows, how they were kind of conceptualizing and orienting themselves to mental and behavioral health supports. And like I mentioned before, that comprehensive in-person training, having all those folks in the same place at the same time made a huge difference. Next slide, please. Obviously, with facilitators, the other end of that ends up being challenges and some of those obstacles that we ran into. Before we got started, a lot of folks were kind of poo-pooing getting integrated care up and running at UHS. They detailed how they used to have collaborative care on site, which for folks who work in collaborative care, people use that term pretty loosely. And once you kind of look under the hood and ask some questions, you realize they never had a psychiatric consultant. They didn't have kind of the 5 pillars in place. They weren't really thinking about, they obviously couldn't drop the bills, do those kinds of things. So there was a misconception about kind of what integrated behavioral health was and collaborative care in specific. So there was a lot of education and increasing mental health literacy around this that had to take place. Obviously, you want to be really diplomatic and not push people away in that sense. So that took a little bit of time. This was another change amidst so many changes that were going on in their kind of system. We talk about systemic transformation and health system transformation. That can be really easy for folks. This ended up being a little bit of a challenge, but they were willing to go with that. The transitional age youth population is really complex when it comes to consent, confidentiality, trying to figure out family versus student insurance. There are a lot of students from a cultural standpoint that did not want their parents to know that they were receiving mental health services. So how do you balance all those things? What kind of narratives and conversations do you have to make sure that everybody's on the same page and you're following legal stipulations? Such a busy site during the school year that it was really hard to set up meeting times with them. Oftentimes, obviously, the student population is a priority, so they had to shift things around. But we ended up making things work with a little bit of calendaring. So a calendar school year is very different than going through the 12 months of a regular fiscal year. So continuity of care for summer meds, service provision, those types of things will be something that we address this upcoming summer to try and figure out how best to approach that, knowing that there's a lot of students that go back home or are going under the care of their primary care physician when they are not at school. And then the interdigitation, how do you kind of interweave the University Counseling Center, health services, the crisis services, all those types of things with stepping up and stepping down. There were a lot of conversations there as well. Next slide, please. I know I just have a few minutes left, but trust that you'll have all these slides after we're done. I won't go into too much detail here, but our clinical workflow is not too far off what a lot of folks would see in their different health systems. PHQ-2, if it's positive, with a PHQ-9, if they meet inclusion criteria for the collaborative care program. The PCP provides a narrative relative to COCM, talks about copays. And then if it's unlikely that an individual will meet that criteria because they have a higher acuity, they're referred to the University Counseling Center, the equivalent of specialty care on the campus. Verbal consent and referral goes into the EHR. They were on point and click. BHCM receives that order and then reaches out to the patient, secure messaging via the student portal to schedule that intake. The BHCM meets with them, and then they go weekly from there. And they are kind of creating the treatment plan, making the recommendations in concert with the psychiatric consultant and the PCP, and then moving on from there with care of that patient. Next slide, please. What did the billing workflow look like? Texas A&M is contracted with academic health plans through BCBS. They are reimbursing for COCM services whereas all other payers were considered out of networked. The monthly minutes were tracked by the BHCM on a BAA Excel registry. And then the BHCM would send that registry with minutes to the billing department at the end of whatever month they were using, where the codes were that were eligible were dropped at that point. And then they were billed to the academic health plans, BCBS, and then payment was reimbursed through there. Texas A&M, again, wanted this to be accessible. So the maximum patient responsibility, regardless of how many services through collaborative care they received per month, was $25. $25 ended up being actually somewhat burdensome. Obviously, college students, they are, eating top ramen and doing all that kind of stuff. So wanted to make this as easy as possible for them. This is something that we're going to be addressing as time progresses. Next slide, please. Some of the challenges, again, explaining COCM to students. So what we did was co-craft a scripted kind of narrative that folks could be able to quickly and easily explain it in layperson language, added that to the EHR, that financial responsibility that we just spoke about, tried to keep that as limited as possible, created a billing one-pager for students to understand all the intricacies in layperson language. Student engagement, we had customized outreach workflows to have messaging and through that secure student portal, and that's the modality that was most used by students, so we wanted to make sure we were leveraging that. We built a time capture into the EHR point and click to make that as easy as possible for billing, and then aligning and coordination of treatment plan. So the treatment plan was sent to the PCP, as an open note. This gets really complicated. If you close a note, then things are pushed forward. So keeping an open note and letting a PCP know they receive it, they review it, they add anything to the treatment plan, and then they close that, which auto sends back to the original sender, making sure we have kind of closed the loop there. Next slide, please. Utilization, I'll keep this quick. We are less than, I have data from less than 6 months. They pushed to March for us, but we don't have up to May yet. They're really, really busy at the end of the year. So they had 143 students referred at that time. 48 were unresponsive. To Patricia's point earlier, this is pretty common. This is just because you refer someone to COCM, it doesn't mean that they're going to enroll. So some measurement-based care numbers that we like to track underneath that as well. 32 decline treatment. Dr. Carlo, who's here, can speak to a journal article that came out a while back that actually delved into why do people decline COCM services. Sometimes it's because of a misconception that the program is really about medication. Whereas in reality, a BHCM can be providing psychotherapeutic interventions that have nothing to do with psychopharm. So we'll delve into that a little bit more with this Texas A&M team as time progresses to figure out exactly what that looked like. Next slide, please. Again, when we grab these numbers from March, 27 didn't enroll due to graduating or moving up in care to specialty care at the University Counseling Center. Again, the time frame of the calendar year for school is really tough. You identify a kid at the beginning of May that needs COCM, but the school year is ending. What does that look like? At the time, they were 4 awaiting intake. They had 31 actively engaged, their MBC numbers there, and they had 4 in relapse and prevention at that point. Next slide, please. Overall impressions of the programs, one of our huge physician champions, the lead PCP, Dr. Tiffany Skaggs, talked about how she loved collaborative care for its coordination of care management, psychiatric expertise, counseling, and primary care seamlessly being delivered into the system their patients are being served. And then next steps for us, looking a little bit more at data collection regarding referrals, outcomes, and fiscal sustainability, root causes of why students are declining services or unresponsive, optimization of care for service provision sites across the campus and for kids in the summer, intra and interstate, fine-tuning clinical workflows, especially around those seasonal ebbs and flows, expanding the COCM program with additional BHCMs, looking at billing optimization, securing additional funding for financially disadvantaged students, and talking a little bit about feasibility of a COCM bridge program for the summer. Next slide, please. That's it. Made it on time. Happy to answer questions.
Well, Hani, that was a remarkably smooth acceleration towards the end there. Thanks for working within our time frame. I will say there's a lot of information to be unpacked in both presentations today, and you'll see in the chat room, if you get onto the Path Forward Mid-Atlantic website. You can follow up with questions after the presentations that you may have, and we'll make sure to get back to Hani and to Patricia with answers, or there may be broader answers we can provide. But I want to thank everybody for participating in today's event. It was great. And particularly thanks to our presenters, Patricia and to Hani, and our supporters, Sylvan Foundation, as well as the Bowman Foundation. So thanks to everyone, and good weekends to all.